I was asked to talk today, but I reached out to Paul, who many of you will know, the Chief Addiction Medicine Advisor, and said to him, I think we should do this together. The main point of talking to you guys is to give you a bit of sense of what mental health are doing and how mental health think about what they can do with you. And the best way to do that is to, present together and talk about it together. And we spent a little bit of time over the last couple of years talking about, how we can do these sorts of things in different ways. I think you've also seen my acknowledgement slide. In the interest of time, I'll keep going, but it's a really beautiful picture the Department of Health have, and I think you know what my role is. So let's talk about integration. Integration is lots of things, isn't it? And there was a lot of talk in our Royal Commission about integration and the importance of it. But it can be integrating into a single system, or it can be, I think in this case, better thought of as all the different components that weave together to create something slightly better than the sum of its parts. And I think that's the sort of integration where we work together with our unique and individual experiences, knowledge, skills, ways of knowing, being and doing, and create something better together, or something more. So there are many types of integrated care, and I think we do need to think before we kind of rush into these things, what are the bits that we want to nurture, and what are the bits that are perhaps less helpful, and what are the things that could trip us up when we try and do better AOD and mental health care from pretty different systems. So I think it's important to acknowledge that we have a dual system in Victoria. It was separated quite a long time ago, and as a result we've had very different philosophies in the ways that we've grown, the ways that we've thought about the same types of things, and the languages that we use for the same things. So when we're trying to talk with each other, clinicians on the ground, we're not using the same kind of ways of thinking. That doesn't mean we're not talking about the same things, because we absolutely are. I've done a whole lot of yoga training, and one of the things, I was sitting in a yoga sort of satsang, and someone leaned over and said, this must be really hard for you because there's all this language that isn't, really neuroscience based. And I said, you know what? I think if you just put this word in for that and this word in for that, it's actually all talking about trauma. And there are many, many ways of talking about trauma, from ancient ways to more modern ways. But I think we are mostly talking about a lot of the same things, just using different language to talk about it. So I think there's lots of ways to do things better. We thought it might be helpful, both Paul and I are going to do this, talk about our personal backgrounds in a little bit of, a tiny bit of detail. I started my training at the end of the asylums, and you can see some of the asylums I worked in there. So from Royal Park at the top, which many of you will have heard of or seen, to St Brendan's in Dublin, where I started my training, which was a very large asylum in Dublin, and then on to Royal Melbourne, where we thought we were going to do things differently and better. But by the time we'd got from the asylums to community care and mental health, we'd completely lost the skills, the knowledge, or even the sense that we were responsible for AOD. And so when I was in Ireland, I actually, my second job as a trainee was in a AOD clinic. And as a psychiatry registrar, I sat in this clinic, I saw any drop-in that came in, I helped people, who wanted to withdraw primarily from alcohol because it was Dublin. I asked lots of questions and took lots of interesting drug histories. You had to say how much alcohol, and then how many shandies, and then how many baby champs, and how many, because people didn't think half the stuff they took was alcohol. So I had this really different experience than most of my peers coming into mental health, and I had a lot of experience with AOD before I even started. And then I got to Royal Melbourne, where I worked in Consultation Liaison in the emergency department. And actually what I was told we were supposed to do when someone had an AOD problem is not offer kind of an assessment and a sense of what we could do or prescribe any medications to help them withdraw. It was to give them a bit of paper with a phone number on it and say, ring this place if you want to do something about your substance use. And that was such a stark difference that didn't really sit very comfortably with me, who did feel equipped at that point to start doing some of the treatment, at least the first conversation. So all of the people in mental health since then, so anyone younger than me, has never really had a good experience of delivering AOD work. And theoretically, yes, we've had to learn a lot of book learning, but in reality, sitting down, actually working through the process, we haven't had that experience. And I think that that's a really important thing to remember when you're talking to us, and when we're not quite understanding what you're saying, it's probably because a lot of us haven't had anywhere near the experience you've had. A lot of people are falling between the gaps, aren't they? So drug-induced psychosis in particular is mostly coming into mental health, and these people are not necessarily getting the value of AOD input. They are getting some, and absolutely every psychiatrist asks about AOD use and understands pre-contemplation and talks about ways you can get help. And we do de facto do a lot of withdrawal in mental health inpatient units, but we're not really holistically trying to help this problem from all angles. Certainly alcohol and depression is another one where a lot of people fall between the gaps, and a lot of them come to you guys and they don't make it to us. Anyone who has trust issues with medical models, you know, they don't want or they choose not, or they've had a bad experience in an emergency department, don't necessarily want to come back to us, and they come to you. A lot of people are pre-contemplative of both addressing mental health and AOD needs. And, you know, let's face it, we've all had psychological distress in our lives, and it takes quite a lot, doesn't it, to decide that you need care or you should go and ask someone else. We all think we can carry on. And I think everyone with trauma, like, I'm not sure that any of us are doing that as well as we could be. When you think about integration, this was just me kind of trying to find ways to demonstrate it visually. You know, do you want something that combines and splits off? Do you want something that's woven together? Or do you want something that has a real human connection? I think probably most of you, like me, want the real human connection. Royal Commission said lots of things, and I know that you know this. I'm going to do it really quickly because I want to get to Paul and maybe give you a chance for questions. But we know that it really flagged that this lack of kind of, you know, having the dual system meant a fragmented system. And made a number of recommendations about changing the ways we do things in mental health services, but also in putting in place the Hamilton Centre, which I know you all know about. And the Department of Health has, in response, and you heard a bit of it from Minister Stitt and from Pam just then, put a lot of things in place to try and start at the top level a structure that will allow for integration. But what it really needs is for us, more of us on the ground, to actually be enacting the strategies. So, you know, there's a guidance policy around inclusion, access, capability and participation. I think we all agree with those. And there is progress, and the progress, you know, at a government level and a policy level has a lot of fancy words in it. I'm not going to read it all out. But we know that what matters in the end for the consumer is how this actually gets enacted. And we also know that you can change a sort of recruitment strategy or a capability idea at this point, and it takes several years for it to really get to meaningful change on the ground. So there is a lot to do. There's obviously an alcohol and drug strategy, and I'm sure you all know about this one. We worked hard, Paul and I, didn't we, to get mental health in this, because it's really important that both mental health thinking about AOD, but also AOD thinking about mental health. Just to give you a little bit of sense of what's happening on the ground in my real system, so the designated mental health services, that's the tertiary, the ones you think of as the area mental health services, they're all at different levels of development. So some of them already had services that did a lot of AOD, some of them had very little. Most of them had some kind of consultation liaison capacity to do AOD, because of course hospitals are full of people with substance use. And a lot of them have increased their CL addiction medicine capacities over the last few years. There have been for quite a long time local opioid substitution services, but only a couple of them, called ADAS is the Austin one, and a lot of community teams have had portfolio holders. So one or two people with a particular interest and focus, or a clinical review, will bring that knowledge and expertise to the discussions. Some of them have communities of practice at local levels, and of course they all have the opportunity now to interact with Hamilton. And again, that's happening at different levels. So if you're at the Austin Hospital and you have a Hamilton Centre at the Austin, of course, it's really easy to pick up the phone to the person that you know. Kerry Alexander's very enthusiastic, you know, easy to get her. Even then, people are not always thinking to do it. And part of it is because the acuity of people coming in the front door with mental health, when you have a mental health lens, it's really easy to focus on the mental health and think about the AOD as a sort of secondary thing. There's an awful lot going on at tertiary level with Hamilton though. There's much more training, and Hamilton have rolled out training. So if people are interested and want to, it's absolutely accessible to get training, but it's not necessarily embedded at every level for every person. And there's a lot of AOD policies now, and once we had that Royal Commission, everyone went back to their policies and changed them from mental health to mental health and AOD. So, you know, even though those things might not feel that relevant on the ground, they do change mindsets, and they do change the way we think about how we plan and develop. And there's a whole lot of innovative ideas out there. There's actually, pockets of real change. There's people reaching to rehab services and talking about how they can give some psychiatry time. There's a lot of nurse practitioners working in this space now. The Rural Echo, I'm sure many of you know about, run by Goulburn Valley Health. It's a great community of practice. I've been to that a couple of times. Really enthusiastic addiction clinicians who go to that from rural areas. And we are talking a lot about how can we get some sort of AOD data in mental health to be able to see if it's changing over time, and use it as a way of incentivising things. The AOD mental health hubs are up and working, and they're going really well. And this is just one slide, but what it shows you, and the blue line is the length of stay in ED, and the red line is the increasing number of people going to the hubs. So in services that have a hub, if people are able to be moved to the hub, then their length of stay is reducing, the length of stay overall. And probably some of that is, directly just the number of people that are not there and able to be seen by mental health or AOD more quickly, and some of it is probably just reducing the amount of people in the general area, and the negative impacts for most of our consumers when they're in an ED environment and being treated in a kind of quick way, and not having the space to kind of feel safe and reflect. You get faster, don't you, when people are calmer? We all know that. The Hamilton Centre have done lots of things, and I know you know about them. I'm not going to read through all of it. I think the main thing for us is that they do provide, consultation services to mental health staff, and so mental health staff can much more easily than before get upskilled, or go back and just check that they know the latest things. The Hamilton Centre provided us with this slide, so thanks, Shalini. It does give you a little bit of a snapshot of the different areas and how many people they've seen, and I think the most important thing from this slide is that there's an equal emphasis on capacity building as there is on seeing people, and we know that there's a huge need for capacity building in our sector. We have a new joint AOD mental health MAC, so that's a ministerial advisory committee. There's a mental health one, there's an AOD one, now there's going to be a combined one. Paul will be chairing that, and it really is an opportunity for us to see gaps and opportunities and feed them to the Minister to think about, the way that we can address those things together. I think the elephant in the room, and I've mentioned this a few times while I've been talking, is trauma, and the real challenges we all have in conceptualising, working with and understanding the different approaches to trauma, and the fact that often all of us want to treat the symptom in front of us and not the underlying things that led someone here, and some of us will be more or less comfortable or have more or less skills to do that. And some of that is really about, humans and our ability to understand and hear each other. And someone's changed my slides, so I'm looking at going, oh, what's on these slides? But really it's all about trauma. And, we know this is all of our responsibility, and that we all need to do things. And I think we do need to think about systems responses. In the absence of being able to have a centralised TTV at this point in history, I think we all need to be thinking about how can we do this better, and how can we share the way that we think about it. There's clearly values to integration and collaboration, which are much more important than just, efficiencies. We all know that our consumers want holistic care, and we all know that we want holistic care. When we go to a doctor, we want them, or a counsellor, or an AOD clinician, a lived experience peer person too. We want to be heard and understood. We want a person to understand the whole of us, and not just a single focus or don't you hate it when you go to the GP and they give that little click box thing that you have to tick through before you get there, and they say, what's your problem? You're like, I can't actually quite condense everything I want down to, I'd like a script, please. We want people to have no wrong door. Whenever someone turns up on a really bad day, we really want them to be able to get their mental health and their AOD needs met. We also want that sense of continuity, because we know that trust. So if you're seeing a clinician and they can do both things, then you don't need to repeat your story, and you also can really build trust over time, and that makes it much more powerful. We also know multidisciplinary care works better than one single provider on their own. We want to include people and make them feel like they're part of it, and that's the consumers, but that's also us. We want to feel part of something bigger, good for our morale, good for our purpose, good for our sense of agency in the world, and we really want better outcomes, and we all know that we can, help one person at a time. But if we really want Victorians overall to be thriving, there's a lot more to be done. This is just my little way of saying, weaving things together, integrating them is not just a two-dimensional thing. You weave a few strands and then you build a bit of a pattern and then you move out and then you maybe go up and you build something that is bigger and more containing and more safe over time. And it's not as simple as just growing in one direction. It is about being interwoven and the solidity that you get from creating a really great strong foundation, so a basket that you can then use to carry a lot more things. So I'm going to hand over to Paul. And I'll just be here because if there's any chance at the end we can answer some questions.
Thanks, Sophie. Now, I'm not going to hold you up too long. It's nearly morning tea time. I thought I was going to get out of speaking at the VADA conference this year, but Sophie dragged me back in. And I thought I'd give you guys a break from hearing me talking. I'm just going to talk about some examples of integration and integrated care. I think Sophie's talked a little bit about the high level stuff that's going on. There is work that's happening to try and make sure that systems are integrated at an up level, but there's also work happening on the ground. And so just some examples from my background, as Sophie was talking about her time in Ireland. I've been working at CoHealth for a long time. We now help to run the clinic at Burke Street. So that's with the Salvation Army. I've had a cafe for a while, so we've taken a clinic to where people are. And we're doing some work with the guys from the Alfred, and so the mental health team at the Alfred. So there's 3 mental health nurses and a psychiatrist come there once a week. So the mental health nurses are there all week. So it's fantastic to be able to work together, to be able to work in with those guys. It happens that Sarah, one of the wonderful mental health nurses, also works at the injecting room. So there was an overdose the other day, and it was fantastic to have her experience there and helping us out. So there's that happening on the ground there. We're doing some work at CoHealth as well with Uniting, which we're really proud about, a project where we're providing addiction medicine services and medical services to people who are seeking help with alcohol. And so working in with the team at Uniting has been wonderful. And that goes back to work that I've done. I may have even spoken in this forum previously about a time where I was working in Shepparton with the team at Primary Care Connect. I don't know if there's any of that crew here today. Where the people would come in, they would see their intake worker, they would be engaged with the AOD team in that service. And then I would be able to come in and provide some medical advice to those people in that service, but they were still held by the AOD team. So really, and then we managed to connect up with Golden Valley Health, and they brought in a psychiatrist. And so the AOD service was holding people, but people were able to get medical and mental health care at the same time. It's one of the most rewarding experiences I've had in working. There's another excellent example from the Whittlesea Mental Health Local. So the crew out there, so it's a joint partnership between NEMI and Uniting again, where right from the start they had this partnership, and it was integrated from the beginning and right through the structure. So this is really important work and an example of what can be done. Importantly, and this, thank you for I think Sarah from VADA helped set this up actually, but this is from Corinne, who sent this to me. She emphasised that the most important thing is that co-location. And I think we all know that. As Sophie mentioned, if you hand somebody a leaflet and then expect them to go and get a service, it doesn't happen. There's a study. There was a study done for people who were in a withdrawal service, and they studied if someone from an AA group, for example, they were given a leaflet for an AA group, what percentage of people that were handed that leaflet went on to go to that AA meeting?
4%.
0%. 0%. Whereas if you had somebody from that AA group come into that service, meet up with people and say, we've got a meeting on Wednesday night, the uptake was sort of 40 to 50%. So this idea that we just hand out leaflets and people are going to go to another service is not realistic. So that's the advantage of what these guys are doing. Everything's on site. The meetings that they have are relevant for everybody. So everybody goes. When there's an AOD meeting, the mental health guys go. When there's a mental health meeting, the AOD guys go. That's integration. And importantly as well, Corinne mentioned this, having a dedicated specialist oversight of the integrated practice. So there's somebody there whose job it is to make sure that integrated work is happening. So that's something this kind of model, I think, is something we really should be striving for across the whole sector. I'm a GP, so this is my little bias section. GPs do integrated care all the time. It tends to be internal. One of the challenges, and again, I've spoken about this in this forum, is getting GPs connected in with the AOD system and the mental health system, as it turns out. Interestingly, people with mental health and AOD problems, so dual diagnosis problems, if you like, in the old language, also have physical health problems, as it turns out. And so there are programs, so in the mental health system, the Equally Well program, which is suggesting that getting people's physical care done as part of that integration is really important. At Eastern Health, for example, they have GPs now based in the mental health service, which I think is fantastic. And so thinking about how we have GPs based in AOD services and everybody based together, perhaps in a mental health local, is a really interesting thing to think about. So good care, what would good AOD care look like in mental health? So there's a whole long list of things here. As Sophie mentioned, an important part of it is actually collecting the data. So knowing how many people have AOD problems when they come into mental health services. I think, and Sophie also mentioned about drug-induced psychosis. I think it's a real gap in what we don't provide. So again, this idea that people come into an inpatient service, they have their mental health care, their psychosis sorted out, if you like, or calmed down to some extent, and then we do the old hand them the pamphlet to get an AOD service. It just doesn't work. It doesn't work. And so I think of the potential models of having, again, that model of that AA meeting, of having the local AOD service worker come in, meet up with those individuals and say, I'm going to be your worker. I'm going to work with you in the coming weeks. I'm starting work with you right now while you're in the inpatient service. I'll come to the community mental health service if that's where you're going to go, that sort of thing. Those kind of connections I think are really important. In AOD services, again, having access, as Sophie mentioned, having access to mental health providers within AOD services is really important. Increasing the capacity of AOD workers in providing mental health work, and it's something that AOD clinicians do all the time, of course. All the time in trying to help manage that, that AOD on one side, mental health, and then that trauma bit. And I think having AOD services more able to provide that trauma treatment, that ongoing established work, as I know at Uniting now, there's 3 practitioners who are providing EMDR to people, and it's fantastic. For me, when I see somebody with their alcohol problem, I can manage that alcohol problem with some medication. That's a good thing, by the way. Medication for alcohol, I just push my little barrow again. But once that's settled down, having that capacity to deal with that trauma, provide that trauma treatment is really, really valuable. So future opportunities, programs developed together from the start, and where they're not developed together, really rethinking them. We've got an opportunity with the AOD strategy to be rethinking how our AOD services are working and thinking about how we start to enmesh these services so that they can work together. Mental health locals and connections with other clinical services I think are really important, and as I mentioned, connections between AOD services into mental health services. And then ongoing medical support as needed for AOD services I think are really important. So I'll rush, we're almost at morning tea, so if there's any questions.
Thank you, Paul. Thank you, Sophie.